Now we talked about what astigmatism is and how our corneal incisions can affect that. Look at this picture. This is taken out of my office window. The left panel is planar with no astigmatism. The right has the exact same view with the same camera. I just got a 1 diopter cylinder lens from my trial lens set, held it in front of my camera and tried to autofocus through it. Certainly my camera couldn't autofocus through astigmatism. So you can see 1 diopter of astigmatism certainly does affect image quality. Toric lenses in general work best with patients who have symmetric, regular, and stable corneal astigmatism. This is just a toric marker that I made. Remember this clock analogy. Rotating the toric lens 30 degrees off its intended axis means 100% of its beneficial effects of toricity are gone. 30 degrees is not that much. It's 5 minutes on a clock. Just 1 minute of malrotation, in this example from let's say 12:14 to 12:15, just that one little bit is 6 degrees. And that means 20% of the power of the toric lens is lost, of the toricity. Here's an example of a corneal topography overlapped on top of a picture of the eye. And you can see this is clean, symmetric, regular, and stable astigmatism. Here's an interrupt photo showing lining up of the toric lens in a particular meridian. Be cautious with toric lenses if the corneal astigmatism is asymmetric, irregular, or not stable. Here's a Map-Dot-Fingerprint or epithelial basement membrane dystrophy causing a lot of irregularity. In certain situations, we want to fix the astigmatism before the cataract surgery. This patient has a very dense cataract, but also bad pterygium. The temptation is to just do the cataract and the pterygium at the same time. But can you really do that? Yes, but not accurately in terms of lens counts, because this corneal topography shows the patient has 9 diopters of astigmatism induced by that pterygium. Here's that patient with EBMD or Map-Dot-Fingerprint. This patient needs to have the epithelium scraped first, wait for the cornea to stabilize, and then now plan the cataract surgery with better K readings and more accurate lens calculations. Here's a patient who had bad epithelial ingrowth, who said she wanted just cataract surgery done, but clearly looking at this picture, 90% of her visual problems are due to the epithelial ingrowth after the LASIK, and 10% of her issue is due to the mild cataract. Dry eye syndrome, like this patient here, can certainly induce irregularities on topography and may even look like a high degree of astigmatism. You must optimize that ocular surface to analyze this appropriately. Sometimes you want to address irregular astigmatism after surgery. This patient has bad keratoconus. If they have a cataract as well, fix the cataract alone and let the patient go back to wearing the RGB contact, do their cross-linking, or they could have a corneal transplant later. Here's a patient with a traumatic injury to the eye as well as a traumatic cataract. We can fix the cataract first and then address the corneal issues later. Another one, an old corneal scar. In this patient, doing the cataract surgery alone was enough to restore sufficient vision to the patient without having a corneal procedure done. This is a patient with a very highly irregular cornea, with some unknown surgical procedure having been done many years ago. It's best not to touch this cornea. Here's a patient with 32 cut RK. It's just too irregular and too unstable to try to address anything there. Here's a patient with a posterior subcapsular cataract, but a decentered LASIK ablation. And you can see that on the pachymetry map. There's no way to fix that with an IOL. So don't attempt to fix astigmatism if it's very irregular, centrally asymmetric, or unstable. Sometimes the best surgery is no surgery at all. There are, however, some times where we can fix any kind of or mild degrees of irregular astigmatism at the time of cataract surgery. And when we've seen this picture here, we saw the LRI. Here's a toric lens. Look at the central cornea, the area within that red circle. That's the most important. If the central cornea is relatively symmetric, then a toric IOL can be a reasonable option. Here's a patient, and you look, and the central corneal zone looks pretty good, even though there's some irregularity of the cornea in the periphery. Here's a patient who had prior conductive keratoplasty causing peripheral irregularities, but the central cornea looked good. Again, there's the center of the cornea, here's the center of the pupil, and remember the topography is lined up closer to that. Let's look at an example. Here's a patient with forme fruste keratoconus, FFKC. This is a referring doctor's mom. Now, important to look at some old records. This patient has done monovision and soft toric contact lenses, so interesting, she didn't need to wear rigid gas permeable contacts, and she was doing a goal of plano in one eye and minus to the other. If you look at the very bottom here, even her 10-year-old records show that in glasses, 10 years ago, she was able to achieve 20/20 in the right and 20/25 in the left. Remember, glasses can only fix regular symmetric astigmatism. And therefore, it tells me that in the right eye, it's essentially all regular and treatable. In the left eye, it's mostly. Here's a quick topography showing that the right eye looks pretty symmetric and reasonable. The left eye has some inferior steepening, as shown here on that panel. When you do a little bit more detailed examination, the right eye looks good. 1.5 diopters of with the rule corneal stone on the right eye, regular and symmetric. We'll use a toric lens there. The left eye, yes, there is some inferior steepening, but centrally it's okay. It's about another 1.5 diopters of astigmatism. So in her situation, we did a cataract surgery, put toric lenses in both eyes, gave her a goal of plano in one eye and about minus 175 or 150 in the other, and we certainly achieved that. And you can see here post-op, she's able to be corrected 20/20 in the right eye like she was 10 years ago, and the refraction is able to correct the left eye at 20/25 just like 10 years ago.